Hello. Okay, so welcome to Physician.Academy. Today we have an introduction to COPD, chronic obstructive pulmonary disease. Please share our talks with others, encourage others to join us. Like us on Facebook, subscribe to our YouTube page. As we grow and our community expands, we can offer more services such as test prep and better lectures. We're always looking for better lectures. So today is an introduction to chronic obstructive pulmonary disease, COPD. Much easier to say COPD than chronic obstructive pulmonary disease. This is a chronic disease characterized by shortness of breath, wheezing, due to a number of factors such as mucus overproduction, airway inflammation, alveolar destruction, and or loss of elasticity. According to the NIH, COPD is the third leading cause of death in the United States. Two major conditions included under the term COPD are emphysema, which is damage to the alveolar walls, causing them to collapse and become less in number, larger in size. This reduces the surface area to which capillaries can reach and exchange O2 and CO2. Second major condition is chronic bronchitis. Constant irritation of airway lining causing inflammation and clogging by mucus. Patients with COPD usually present with both these conditions. As such, the term COPD is the most accurate way to describe their cluster of symptoms. Diagnosis and causes. This is a progressive disease. It's progressive and shows very little symptoms at the start. Symptoms are commonly those associated with other lung conditions, such as long-lasting cough accompanied with mucus, wheezing like asthma, tightness in the chest. Severity is directly dependent on the amount of damage done to your lungs. So the longer you have this problem, then the worse it gets. Because of this, patients' history may often have a record of smoking or exposure to harsh air pollutants through environments like work, or if you live in Southern California, like living near the harbors where there's a lot of trucks that go by, or living near a freeway. The longer the exposure to the above mentioned circumstances, the higher the chance of the disease progressing until the patient must seek medical attention. More rarely, a genetic condition termed alpha-1 antitrypsin or AAT deficiency can be responsible, as it puts patients at a higher risk of developing lung diseases, inherited commonly through the PiZ gene or PiZ gene. Alpha-1 antitrypsin or AAT deficiency is due to malformed AAT proteins being produced in the liver. This hampers their ability to travel through the bloodstream. AAT deficiency is responsible for protecting, or AAT is responsible for protecting several organs from being harmed by other proteins. The deficiency causes a lack of protection in the lungs, leading to an increased inflammatory response. Many can live with the condition relatively unaffected. It is estimated that 1 in 5,000 people have AAT deficiency. Comorbidity with liver diseases can lead to early onset emphysema, which responds to asthma treatments. Family history as well as personal patient history needs to be confirmed. Smoking is the leading cause of lung-related illnesses in AAT deficiency patients, but an onset of lung disease, or COPD, without any previous history of smoking can also indicate AAT deficiency. So, as we all have experienced, we have patients who say, I have a grandfather, or my grandfather smoked all his life and never had a problem. They may not have a deficiency in AAT. However, your patient might, and that might be why they're presenting with problems. Don't forget, grandfathers are not, pretty far genetically removed compared to parents. Tests. So blood tests to check AAT levels are genetic tests, are ways to confirm the deficiency. A standard physical can be used to listen for wheezing. Lung function tests, such as a spirometry, can tell you an estimate of lung capacity or performance. Chest CT and chest x-rays can give you a look at structural abnormalities in the lung and airways. Arterial blood gas tests to check O2 levels in the blood are also part of the tests that are done to diagnose COPD. Depending on severity, different treatments will be suggested. Because COPD can cause systemic complications and because there is no cure, most treatments rely on slowing down the progression of the disease, relieving the symptoms, and removing the irritants from the patient's environment. Lifestyle changes can include quit smoking. We tell all our patients to do that, obviously, but here's a good example of why. Becoming practiced at breathing exercises can help. Exercising to increase endurance. A patient must be very careful to exercise caution, as they can induce shortness of breath with too much exertion. So exercising to increase endurance, but exercise caution. I like that. Some irritation can be treated with long or short-acting bronchodilators, sometimes in combination with corticosteroids. Maintaining general health and receiving flu vaccines to prevent further complications. Oxygen therapy, depending on severity, can be used all the time or when needed most. So oxygen therapy. Surgery is a last resort. Bulectomy to remove enlarged alveoli or a complete lung transplant. Removal of damaged lung tissue can also help in some patients. That's the bulectomy. Of course, the best thing is prevention. So if we can have our patients avoid smoking, which is the leading cause of COPD, that would be helpful. Avoid lung irritants, including secondhand smoke or chemical fumes. This is why air pollution has become such an issue. So this concludes our introduction to COPD. We're going to have another lecture to deal with more details, as well as to deal with other treatment options. I hope you enjoyed our brief introduction to COPD. Please share our talks with others. Encourage others to join us at Physician Academy. Like us on Facebook. We have a Facebook page. Subscribe to our YouTube. And as we grow our community with your help, we can expand our services to offer test prep as well as better lectures. Thank you for